received his medical degree from Baylor College of Medicine, completed his general surgery residency at the University of Cincinnati, and fellowships in surgical research, the University of Texas Medical Branch in Galveston, and colon and rectal surgery at the University of Minnesota. Since then, his trajectory has been one of continual success. He's been recognized by numerous awards. His service as an ad hoc reviewer for 11 journals, his election to the executive councils of the American Society of Colon and Rectal Surgery and the International Society of Laparoscopic Colon and Rectal Surgeons, and his service as an associate examiner for the American Board of Colon and Rectal Surgery. His research is focused on the cellular and tissue response of the gut to chemotherapy and has received competitively awarded funding from the NIH and the American Cancer Society. His clinical and laboratory studies have been reported in 50 publications in high-impact peer-reviewed journals, innumerable invited lectures, 15 textbook chapters, and 2 books. Please join me in welcoming Dr. Papaconstant, Professor and Chairman of the Department of Surgery, Texas A&M University System Health Sciences Center, Scott and White Memorial Hospital, who will speak to us on a most timely topic: implementation of surgical safety checklist, lessons learned at Scott and White. Dr. Papaconstant.
Thank you very much. I was really excited to come to San Antonio. I've really had some very fond memories of college, some of them that my friends tell me about, I just can't remember. But anyway, it's fantastic to be here, and thank you so much for the invite and the kind words, Dr. Pruitt. I wanted to talk to you today a little bit about a surgical safety checklist. And you know, there's nothing more humbling than being in charge of implementing something as important as this, and the complexity which comes with the implementation. I will admit that I'm not an expert at it. I've implemented it. I've learned a lot of lessons over the course of the few years that we underwent the implementation and rollout. So I'm really here to kind of talk to you about the lessons that I've learned and the lessons that we learned at Baylor Scott & White. I have no relevant disclosures for this presentation. Check. And here we go. So in 1999, the Institutes of Medicine published their landmark study called To Err is Human. And within that study, they actually talked about surgical associated errors. It was quite remarkable, the incidence of patients undergoing wrong site surgery, wrong procedure surgery, and surgery on the wrong patient. It's estimated that in the United States, about 27 million operations occur each year. The Joint Commission estimates that there are about 2,000 surgical errors each year. That accounts for about 40 events per week. I mean, that's a huge number for a never event. So what has spurred from this is patient safety initiatives. This includes universal protocol, timeouts, surgical safety checklists, all designed to reduce harm and improve outcomes. And really, these checklists came out of the airline industry, where they noted that the human memory was fallible, that we're prone to skip steps, especially during complex situations. The checklists were designed to standardize things, to provide consistency, and to enhance communication amongst the team members. Checklists have been used in healthcare. There are 2 very notable publications. The first was in 2004. This was by Barinholtz and colleagues. In this study, they actually used a bundle process that included a performance checklist to reduce catheter-associated bloodstream infections from about 11.3 per 1,000 catheter days all the way down to 0. So very effective outcomes. The one that we're probably most aware of is that of the surgical safety checklist, where Dr. Haynes and colleagues showed that implementation of a checklist reduced morbidity and mortality in a global population. Now, if you do a PubMed search and you use the keyword checklist, there was a significant inflection and increase in use of checklists in studies based on quality in the red and surgery in the blue. And you can see those inflection points closely correlate with those two papers. So checklists are simple, they're rapid, they're easy to implement, and they improve outcomes, and is likely the reason why we've had widespread adoption of checklists. Now, although you have immediate approval in the short term, there's really no strong evidence of sustainability. And that's really the issue and the thing that we want to focus on. So the purpose of my talk today is really to talk about personal lessons learned from implementing the checklist. We're going to talk a little bit about successes and then also about some epic failures. So I'm going to give you a little background about our institution. We're a 636-bed tertiary care hospital with 27 operating rooms. We perform over 18,000 operations per year in that facility. We're a multi-specialty group practice. We're an employed physician model, and we actually implemented a surgical safety checklist September 1st, 2010. Now, from the beginning, Dr. Roy Smythe, who was the chairman at the time, was a great visionary. He actually was focused on improved outcomes and on patient safety, and he was always trying to find out how we could do things better. At the time, I was actually involved in developing standardized order sets to improve SCIP and SCIP outcomes. And he actually called me into his office one day and said, "Harry, I read this really exciting paper. I have the perfect job for you." I was a little scared by that because, you know, you always have to be careful of chairmen telling you you're the perfect man for the job. It usually means it's something that they don't want to do. But again, I looked into it, embraced it, and moved forward. Probably one of the first papers I read besides the Haynes paper was this editorial by Boston colleagues. It was a reality check for checklists. And what he stated was the basic mistake in checklist success is the assumption that a technical solution or a checklist can solve an adaptive problem, a socio-cultural problem. You need to get them both right. And probably the thing that we most commonly forget when in implementing a checklist is how to address the culture and how to address cultural change. So when we think about change, and specifically change to a set of very high-functioning, highly intellectual people that do things on a repetitive basis, change is usually met with somewhat of a resistance. You know, the first response that you usually get is, "What? You're trying to ask me to do something different?" And the initial reaction is really to hold on to the way that you do it because it's been so successful to us for such a long time. But really, in order to move forward and to get the achieved end result, we have to accept it, and then we have to implement it. So taking those things in mind, we actually sat down, and with the focus that I had at the time on quality, safety, and outcomes, I really mapped out what was possible with the checklist, and it really correlated well with what Dr. Atul Gawande and colleagues did. We incorporated the SCIP, the antibiotics, temperature management, DVT prophylaxis, and that could actually end up resulting in a decrease in surgical errors, increase in surgical safety, improvement of efficiency and outcomes, and we could actually track that using NSQIP. So it was something that was really the whole package, and that was something that I thought was very appealing. So we used there's a checklist for checklists that you can actually get out of the checklist manifesto, and we used that in order to develop, draft, and validate our checklist. We got a multidisciplinary team, including 3 surgeons, myself, an orthopedic surgeon, and then a neurosurgeon. And I chose those people specifically because I thought they were going to be the hardest to convince to do the checklist. And I thought if we started together and we started working on the elements of the checklist, that I would get more buy-in. And I think for the most part that worked. There are a couple of things that I'll talk about that were challenges, but they were easily overcome. So we wanted to make sure that in the development that we had some clear objectives, that we utilized that each piece of the checklist were critical safety steps. And then when we drafted it, we wanted to utilize those natural pauses, use simple language, and try and limit the number of items that we had to do for each checklist. Now this is actually where we drifted a little bit. In having neurosurgery, orthopedics, and a colorectal surgeon, we were kind of focused on our areas. And probably one of the things that we should have done early on is try and make sure that they were common elements for each of us. What we tried to do is adapt it too early and adapt it to everybody. So we focused a lot on things that neurosurgery wanted to do, and we included it in the checklist. And that ended up being a significant dissatisfier once we implemented it out. Next, we did the validation, where we did a focused trial. We did some significant modification, like I told you, and then we ended up trying to see how it fit within our workflow. And this pilot trial was just really important. We spent our time on the piloted trial. Probably spent about 6 months just continuing to try it out, doing some different iterations of the checklist. And this also allowed us to talk about its successes in order to get more buy-in and more people interested in participating in the checklist. And after about 6 months, we had people that were asking about the checklist and when we were going to start it. Education was really important. We had continuous education throughout the entire process. We were providing information on why we were doing it, how we were going to do it, and we used multiple methods. We used online video education modules. We used CME credits, frequently asked question emails, meetings, as well as posters. And all of these were actually designed to be a cultural fit within our institution. And to give you an idea, this is actually some of the posters that we had made. Our institution has about 100-year surgical history. It was basically founded by 2 surgeons. So we utilized some old pictures that we had in order to bring some of that historical element with the new paradigm of surgical safety. This, although was a very big popular hit, what I found out about a year or so later after we implemented the checklist was one of the cardinal rules that you don't do when you implement a quality improvement project, and that was actually a mandate. So anybody in here see where the mandate is on this poster? There's one word. Required. Required. I get more comments about that one word on these posters, and we didn't use required in almost every other piece of our education. So this was one of those hard kicks that I learned during the implementation process. If I would have taken that word out and just left September 1st, 2010, the intent would have still been there, the date would have still been there, but the surgeons, the anesthesiologists, the nurses wouldn't have felt that it was something that was required. So what we ended up having was this surgical safety, our surgical safety checklist. It looks very straightforward. It was easy to implement. Not a lot of words. I think we fit the goal of the checklist for the checklist. And what it allowed us to do, and because Dr. Smythe and the team had the forethought to do this, is that we actually planned some studies around it in order to address some significant concerns that everybody had. The first was surgical team perspectives. You really don't know how people feel about things unless you ask them, and you have to ask them in an anonymous way. So we created a questionnaire in order to address this. We looked at the impact on operative efficiency because that was something that all of our faculty and everybody was concerned about at the time. We also looked at and ended up looking at checklist performance. We did a few innovations to try and address this, although I don't talk about them here, but we were trying to do things to get people more excited using modern day devices such as cell phones, iPads, using things such as QR codes and NFC badges in order to do checklists and timeouts in the operating room. And again, I'm not going to focus on that, but that's something that I think was really critical that allows us to think about what the next steps are for things that are so mundane like a checklist. And then the last piece is we're actually wondering what the patients felt about checklists and about surgical safety. And I'm going to get into some of that over the course of the next few slides. So this really kind of shows a diagram about our rollout. So we started a little bit before September 2009, doing our pre-implementation period. And then September 2010 was when we implemented it, and then our post-implementation period. The monitoring and reinforcing was probably something we should have spent more time on. Our monitoring and reinforcing was really the first week of implementing the checklists, and then just receiving the checklists, and then just kind of taking a look to see if people were participating. We could have done a better job there, and that's a significant focus of what we're going to talk about today. And then at 1 year, we decided to do our outcome review. So let's go into surgical team perspectives. So this is a paper that we published in the Ochsner Journal. We did a pre and post survey focused on things such as communication, patient safety, quality of care, and teamwork. Had a total of about 25 questions. We had a good response rate, about 53 surgical team members, 53% of surgical team members responded, and that was about 450 surveys. We found that overall there was improvement in all of these categories, but there are a few things that I want to show you about the results, which at least initially didn't pop out to us, but then when we really started looking at it, we saw some hidden meaning in the data. So one of the questions was, is a timeout really necessary in all cases? What do you guys see? Now we did see an increase, and it was significant, but what do you see? You see the nurses have a very, very uniform and high level of agreement that the timeout is really important. So at least at our institution, nurses really drive the timeout. They're the ones that are responsible for it. I thought what was interesting is that both anesthesia and the surgeons had the same lower level of agreement. And I'm not sure why that is, because a timeout is something that's required by the Joint Commission. But again, what this told us is that really the nurses needed to help drive some of the patient safety that we needed to do in the operating room. Now, in terms of communication, does a surgeon always inform you of critical events or anticipated difficulties before they occur? What do you see here? It's pretty obvious, right? The surgeon thinks he's doing a great job, right? Nursing and anesthesia are not picking up that same information from the surgeon. And it's the same thing here for the operating room with operative blood loss greater than 50 mLs. It's not to the same degree, but it's the same thing, right? Why is that? I mean, there's a significant discordance between what the surgeon perceives and what everybody else perceives. This isn't novel. This has actually been reported in a couple of other papers. One was in American Journal of Surgery in 2005, and the other one was reported in the Journal of Nursing. So communication is a two-way street. You got to have a communicator, you got to have a listener, and it's got to go both ways. So is it truly the surgeon's not communicating, or is it the fact that what he's communicating is not actually being picked up by the people that by the nurse and by the anesthesiologist in the room? I'll tell you, I don't have the answer to this at our institution. We're setting up team training. We're setting up standardized way that we communicate. I'm hoping, we haven't actually looked at it, but this is one of our future studies. I want to see how this team training can actually improve the communication and the perception of communication among these groups. But I would say that this is one of the most important things that we need to address at our institution. The other thing we found from this perception study was how people felt about the checklist and what it improved. Now, clearly, patient safety, about 2/3 of people agreed that patient safety was improved. Another 2/3 believed that patient care was improved. But look at OR efficiency. And then when we actually looked at the anonymous feedback that we got, we were hearing a continual theme. It takes too long. It's not efficient. It increases delays. And clearly what this meant to me is that we needed to provide more data to our physicians on efficiency before we were going to get total buy-in. So when you think about OR efficiency, you're thinking about the time to perform a checklist, decreased number of cases per day, an increase in turnover time, an increase in time in the operating room. At this point in my career, I was like, and I'd spent so much time on this, I started thinking only in one dimension, and that dimension was time in the operating room and time it takes to do the checklist. And I was like, it takes 2 minutes. There's published data that says the checklist takes 2 minutes to do, and I just did some very simple math in my head. 2 minutes, 7 operations a day, and I'm being generous, right? 14 minutes. I can't do a colectomy in 14 minutes. I mean, I could probably do a gallbladder in 14 minutes, but it's got to be a hanger, right? I mean, it's got to be something that's really easy that you can do laparoscopically to do 14 minutes. So I said, okay, no brainer. This is going to be a great study. I'm going to get the data that I want, and they'll be able to give it to my faculty so that we can, so that we can then move on. So what we did is this OR efficiency study. In our pre-time period, we had about 17,200 cases, and in the post-period, we had a little over 18,300 cases. We specifically looked at operating room time, wheels in to wheels out, operation time, incision to close, first starts in room on time, and the incision on time. And then I actually threw in direct operating room cost, because if we were really doing the checklist right, we would have a reduction in, we would be ready for the case, we would have a reduction in things that were opened inadvertently, and we should drive the cost down. And then the other one we looked at was same-day cancellations. Well, here's our data. So as I anticipated, all operations, the OR time and the operation time was no different. If you looked at first starts, and there was a total of almost 5,000 in each group, in-room on time was no different, 58.9% versus 57.6%. Incision on time was significantly lower, but I would say that it's not that much lower. And then cost per case, though, was about a $68 reduction on the average cost per case. Now, we're having some assumptions here. The assumptions are that no contracting changes were made over the course of this 2-year period, which, at least by my estimates and by talking to our VAC committee, there were no significant changes in contracts. I don't know what the changes in prices were for the equipment that we had. But if you actually calculate out 18,400 cases, there was a $68 reduction per case. That was a savings of about $1.3 million. That's data. That's data that I can actually provide to people and show them one of the benefits of the checklist. Now, for OR efficiency, if you look at the numbers pre and post, there really was no difference in cancellation rate. So really, just to summarize this study, there really wasn't that much of a difference. The only difference was a slight decrease in incision on time, but there was a significant decrease in direct cost per operation. So I took this to a faculty, presented it, showed them doesn't adversely affect OR efficiency. We can actually potentially reduce direct cost per operation by improving communication, clarifying equipment needs, and reducing waste. I was really good about myself. I really was. But did we really address the problem? So why would somebody who is dedicating their lives, their career to saving lives, decide to not use a checklist and deviate from the goal of patient safety? And the revelation came to me when I talked to my circulating nurse. We have a great relationship. And she actually said, it's really about the time and the amount of documentation I have to do in the operating room. I don't want another sheet that I have to fill out. If the case is 20 or 30 minutes, I don't have time to finish the documentation I have to do for the case, let alone the checklist paperwork. So that was something that was very enlightening. Clearly, we had to do something to make it easier. We had Epic coming in, so my goal at that point was to try and make sure that we incorporated things in Epic to make it easier for our nurses. But what about the surgeon? Well, this was a time where we were, as most hospitals were, in a little bit of financial trouble. We were actually pushing our doctors, saying, "Okay, see one more patient in clinic, that'll increase our volume by 5%, and do more." And that was coming from the top. What they were viewing it as if I have to spend extra time to do a checklist, that means there's less time for me to generate RVUs, which is contrary to what you're telling me to do. So clearly it was a messaging problem. We hadn't really organized the message that we needed to provide, and we didn't give it in a manner that made sense to our surgeons. So the lesson here was seek out the interests, seek out the why that underlie the position that people take, and the position that people were taking at the time was inefficiency. And I think you need to be really careful about giving conflicting messages, or at least messages that are perceived as being conflicting. And in this instance, really leadership is what's going to help break down the barriers, and that's what we've tried to do over the course of the last few years. So about 14 months after we had the checklist, it happened. What is that it? It's a wrong site surgery. So it's a big problem. I get this phone call from risk management. Trust me, you never want to get a phone call from risk management. We had a provider who, excellent provider. I mean, he's a great surgeon who put a stent up the wrong ureter. We did a root cause analysis. The checklist was performed. All the boxes were checked. The team actually said we went through the entire checklist. The consent was correct. Again, a respected surgeon. Problem was inattention to detail. And what was interesting is that it wasn't at the RCA that we determined this. It was the conversations that we had afterwards, one-on-one, saying, yeah, people are doing the checklist, but, I just get the sense that they're not really doing it the way it's intended to be done. And that's a key concept, is a checklist is really just a tool. A tool is only effective if it's used as intended, and that's really compliance. And compliance is associated with the desired effect, right, which is reduction in harm of the patient. So thinking about some definitions about compliance, completion, accuracy, participation, compliance is used as intended. Completion is just filling it out. Accuracy is filling it out correctly. Participation is really just turning it in, right? So we designed a study where we actually took our checklists that we had over the course of that first year, and we looked at, we designed an objective tool to measure compliance. We looked at completion scores, accuracy scores, and then came up with compliance. We really just did some spot tests on a weekly basis and looked at 671 total checklists. And what we found was at least the participation rate from week 1, which was about 33%, and all the way out to year 1, which was 94%. We had some times where we were hitting 100%. I think the 94 was there because we had a few checklists that were probably thrown away. But still a definite increase in participation. And if we looked at the overall scores, our compliance was 69%. Now, quite frankly, I'd want it to be 100%. But the reality is that when you look at some of the other checklist studies, they're showing significant improvements at 60, 65%. And that was actually the study done by Haynes and colleagues, the initial surgical safety checklist. And here, this shows the component of completion and accuracy. What I found interesting is that when we actually broke down the checklist into their individual breakpoints and elements, the time that we performed the best was in the timeout. Why is that? It's because it's a Joint Commission requirement, and we've been doing that the longest. right? So, but even so, we still weren't doing it. We weren't doing it at 100%. What about perfect scores? Was there any checklist that was perfectly done every time? No, none. There was always something within that element, within that checklist that wasn't done well. Where we performed the best was actually on the timeout and the sign out, and again, we're only looking at about 60%. Now, this isn't novel. I mean, there are actually a lot of papers that are now being published about the performance and about the compliance, the poor compliance that we have with checklists and with timeouts. And this may be why we're still seeing that 40 cases per year or 40 cases per week of wrong site surgery. And really, the bottom line is that you get what you inspect, not what you expect. And what that means is that we really didn't put forth a process to audit and to make sure that we were performing the checklists correctly on a regular basis, and we didn't provide that feedback rapid enough to our surgical teams. And really, that's the way you maintain compliance. And through that, you want to achieve long-term sustainability. So for sustainability, probably there are two things that are really challenging and really difficult for sustainability of things like checklists and quality improvement projects. The first is complacency. Now, complacency is induced when an organization thinks the problem is solved. I'll admit, I thought the problem was solved. We had the checklist, we implemented it, we had some preliminary data and things that were telling us we were going in the right direction. I was complacent. I should have been thinking about and should have spent much more time investing into audit tools, how to do that continual improvement wheel, the plan, do, check, act. And then the last thing is making sure that people were accountable for their actions and accountable for participating. We ended up having that drift or erosion in performance, and we had a significant workaround with our checklist. The other thing that you have to think about for sustainability is the concept of normalization of deviation. Now, what that is for a quality improvement process that has standardized steps, if you omit a step and no one protests and the patient does fine, guess what? That deviation is now accepted as normal, and you're going to have more deviation that's going to occur. And that is the biggest threat to quality and patient safety. And the only way to do that is to have mutual and team accountability. What we've done to combat this is that we've implemented a policy where if there's a near miss, it has to be a debriefing within 24 hours, and that there needs to be a team-based root cause analysis. It's got to be done quick, because if you don't, people forget about what happened in the operating room and what the real crux of the problem was. We as leaders want to make sure that we address any system issues, and if there is any behavioral issues that need to be addressed, then we can do that at the same time. And I got to tell you, that's probably the thing that's the hardest, is trying to adjust behaviors. So what we did is we have scheduled assessments. About quarterly we get together. We talk about, are we still using the process as intended? Are the outcomes moving in the desired direction? If either one of those answers is no, or we're not satisfied with it, we actually look at the checklist and we bring in people and teams to help us identify what the best next step is. And then we have a yearly assessment of competency where we actually bring the teams in the operating room. We actually do it during their operative day, and then we do a simulation to make sure that the checklists are being performed the way they're intended to be performed. We've just started that. Our first round was in July. We've actually called that Surgical Safety Week. We chose July because that's when the new residents come in and we can get them all trained at the same time. And that's when we have the majority of our new faculty join at our institution. Now, we've talked a lot about the checklist, but what we haven't talked is about how patients perceive the surgical safety and the surgical safety checklist. Now, as physicians, we all know that these safety initiatives are fairly well accepted by the surgical team, but can they be perceived as being very impersonal by the patient? If you were lying in your hospital gurney in the in same-day surgery, and you had 4 different people walk up to you, ask you your name, ask you who your surgeon is, ask you what the procedure is that's being done, I mean, does that really make you feel like people know what they're doing? Huh? Yeah, maybe the opposite. Exactly. And you know what was interesting? I didn't even think about this. It was actually one of my residents that brought it to me, and she said, well, you know, maybe we ought to ask patients about how they feel about all this. I thought it was a brilliant idea, because you know the reality is the perception in the lay public is not known. Now, why is this important? Well, you know, we're moving from a doctor-centric to a patient-centric healthcare delivery system. There's a lot of emphasis that's being put on the patient satisfaction and quality. And the reality is that our reimbursement is going to be tied to patient satisfaction. Regardless of whether we think it's correct or not, that's how we're going to get paid. So we did a very simple survey, again, another survey, on patient perspectives to surgical safety. We did 20 questions, gave it to all patients that underwent elective surgery. They had to have at least a 24-hour hospitalization. We offered each of the people that participated to come and join in on a group session where we would get some qualitative feedback. So we had about 110 people participate, and overall from the questionnaire, the perception of safety was actually high. I mean, on a Likert scale of 1 to 7, I think the average score was about 6.2, 6.3. That's pretty high. But what we did find is what you would expect, that patients undergoing their first surgery had a negative correlation. What was interesting was that patients with higher income also had a negative correlation towards patient safety, which really meant that the higher the income, the lower the perception of safety. Right? Qualitative feedback sessions, I think this is where the money is. Qualitative feedback sessions. The patients really focused on an improved sense of safety with physician trust and physician explanations. And see, here's some quotes that we got. You know, the doctors came in, explained what was going to happen, what I could expect, and that put me at ease. It made me feel really safe when my doctors came in before my surgery, talked to me, and introduced himself or herself to my family. Really powerful. I mean, I tell you, I think that physician-patient relationship is something that we may have drifted a little bit away from. What about the negative? What about the negatives? What decreased that sense of safety? Miscommunication was number one. And you know, the miscommunication wasn't necessarily in the operating room. It was actually after the patient was operated on and up in the floor. The surgical team was excellent, but my hospital stay, once I got to my room, it just fell through the roof. It was like there was no communication. So we've implemented an electronic medical record, right? We've implemented all these checklists. But what we haven't done is we haven't really focused on the patient and spent time communicating in front of the patient, doing team rounds, et cetera. And I think they noticed that. So for surgical patients overall, they did have a high sense of safety during their perioperative experience, but they were most comforted by the physician-patient relationship and the interactions that foster trust. The greatest opportunity I think we have is with the nursing surgical team communication. Again, I think that this is where we're going to end up putting a lot of focus on moving over the course of the next year or two, and I'm really excited about that. So in conclusion, checklists are simple tools. They're complex to implement and adopt, and that's really because of that culture change that's required in order to improve that patient safety culture. Opposition is going to occur, but what you got to seek out is the why that underlies that negative position, because only then can you apply that leadership in order to improve the perception and improve the buy-in. What's often overlooked are strategies to maintain sustainability, and this is the area that we need to focus on, and that's auditing, standard auditing, feedback, a continual improvement cycle, and allowing that checklist to become more adaptable to the needs of the surgical teams. Also need to develop strategies to avoid complacency and the normalization of deviance. And last of all, don't forget about the patient and the patient experience, because that's really why we're here. Thank you.
sure about
Yes.
patients being upset with multiple people communicating back and forth with them. I think that if the surgeon tells the patient we're doing this for your safety, because first there's the CRNA that sees the patient or an anesthesia resident, then the staff anesthesiologist, then our OR nurse, and then the resident and the surgical faculty. But if we tell them, you know, that this is for their safety, and I'm sorry, I'm going to ask you if you have any allergies. I've seen other people write in the chart, none. The note from the clinic said none, but then the patient said, yeah, I'm allergic to penicillin.
Yeah.
So it does work if you inform the patient ahead of time.
And I think that's the key. You know, there has to be some scripting. You know, when you go in, you tell, hey, I'm asking you these questions for your safety. We don't have that scripting. So I think that's why there was some concern by a few of the people that spurred this study. So.
Any questions? Dr. Ramos.
Dr. Figueroa first.
You're such a suck face. Dr. Ramos.
Excellent talk. We've been interested in looking at these checklist for some time. It really works. But this is just a few hours of the experience of that patient. And what they have proposed is to have a checklist from the time that the patient goes into the hospital to the time of the patient getting dismissed. And to have the different components of the postoperative care, to have those checklists also available for particular patient. And that may improve the safety further because, of course, the adverse events occur in the operating room, but the adverse events of the postoperative part are huge.
Sure.
And
Yeah.
then when we're just looking at one photograph of the problem, I think we need to extend it further.
No, I agree. I mean, you know, one of the things that we're actually working on now are reintubations in the PACU. We have a significant number of patients that get reintubated in the PACU for one reason or another. You know, they're extubated too light in the operating room. You know, there's this focus on getting them out of the operating room so that we can do more cases and move things along. We need to probably develop a checklist or a better criteria about when do you extubate the patient, when do you take them over to the PACU with a T-piece, et cetera. So, you know, I agree. And then even on the floor, you know, that's what the enhanced recovery pathways are. They're essentially checklists in order to improve and help that patient accelerate and improve their postoperative care and outcomes.
So, you know, all of this is really about culture at the end of the day, from top to
Bottom.
to bottom. But kind of along the same lines of Dr. Ramos, since the OR is one very important event, you know, in the care of the patient, how have your patient safety outcome measures, you know, on the surgical patients that's got a light? What is the pre and post on those metrics?
Sure.
In regards to patient safety and outcomes?
Sure. So in terms of
as a result of
the checklist.
Yeah. I mean, I don't know whether you've taken a hard look at that.
We have. So, you know, it's since those never events, wrong patient, wrong site, wrong procedure, surgeries are very small. There's really has not been a significant difference, and we're talking about one event every 2 years. But we actually did look at the quality metrics, the quality performance metrics, such as skip performance, how it related to outcomes, and we used NSQIP for looking at outcomes. And what we found is that we increased our skip metrics from about 90% to about 97%. You know, it was probably 93 to 97. Still a significant increase, which equated to about an increase in about $1.2 million of reimbursement. But the reality was that we really didn't see a significant decrease in our surgical site infection rate. There was no decrease in mortality, et cetera. So, but I think that the issue here is that we were already performing at such a high level that even though we improved the bar, we got money for it, we really didn't do anything that affected the outcomes, right? Which I think is why we're now staring down the barrel of SCIP being completely eliminated from quality and value-based purchasing starting in June.
On the other hand, patient satisfaction can also be an outcome measure.
Yes.
So if the culture from top to bottom really gets inculcated, and in fact communications improve, on the inpatient ward after surgery and so forth, that's going to be an outcome that will certainly improve over time.
Oh, absolutely, and that's gonna improve with better communication, and absolutely, I think it will. But I think your point about this being from top to bottom and being really a leadership and aligning goals is a critical one. And there's nothing that causes an organization or an institution to lose focus on those goals than money. And a lot of this was done at a time where we were financially challenged, and there was a significant focus that was put on productivity, et cetera, which I think took a lot of people's eye off the ball. And now we're paying for it. We're having to go back, and we're having to readdress some issues that we may not have had to do if we focused on quality, because the money will come if you focus on quality.
Dr. Dent, did you have a question? No. Dr. Pruitt.
That's a very impressive experience, but people are writing now about checklist fatigue. What steps have you taken to prevent that, or have you noticed it?
I think we do have checklist fatigue. I think the answer, the immediate response for a problem is to create a checklist. I don't have an answer for that. What we've tried to do is we've tried to incorporate things such as our standardized order sets into Epic, so that it's really easy just to go through and incorporate those things, those checks into the order set. But that's, I think you're right. I think checklist fatigue is a real phenomenon. We have to decide where we want to use that and where we're going to have the biggest opportunity for improvement.
At your closed shop, who drives it? Is it nursing or the surgeons or the anesthesiologist?
Yeah.
Somebody has to be a maven,
Yeah.
to push to make it work.
Yeah.
And that's why you get the drop-off. If you don't have somebody there.
Yeah, so what's interesting is in the perception data that I gave you, you can tell the nurses drive it, because the nurses are the ones that really truly embraced it. The problem is that the nurses get a lot of pushback from the physicians. So I think that may be why we've had some of the decay. I'd really like to see this be owned by the physicians, because we're the captain of the ship. I mean, the OR is our area, right? I mean, we should be driving that. But that's a culture change.
It's really important that we analyze our system, so congratulations for doing that. One of the ways in my role as a disruptive physician that I try to combat checklist fatigue is at the very beginning of our OR timeout, they say, this is Mary Jones, hospital number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and there's a big chorus of, yes. I say, I can't confirm that hospital number. Would somebody check the wristband? And it kind of alerts everybody to, you can't just have a chorus of yeses every time somebody calls something out.
Yes, yeah, you're right. You're right. And what's interesting is that you're supposed to, by JCO requirements, you really need to use the wristband in order to make sure that that's the right patient. We actually had the same drift, and in an independent audit, we only had 33% of teams checking the wristband. What they were usually checking was the monitor from the anesthesia screen and the consent. And you know what? What if the wrong patient had rolled in? You're in the right room, the wrong patient has rolled in. Yeah.
Do you have teams that just work with that neurosurgeon? Does he get the same team, or is it the team du jour and rotating? Because the reason I ask that, I had the privilege of working with the same tech for 29 years, and we're still working with the same OR nurse for 25 years, and I was very proud of it until both of them told me they were the last two who would work with me. and the anesthesiologist took their risk of who got the short straw for the day. But it did make a difference. And as soon as my nurse went to a 12-hour shift, Wayne and I had her 5 days a week in our ORs, and it was just absolutely fantastic.
Yeah.
But now it's just hit and miss whether we get her, and so, you know, it's this sporadic person showing up periodically.
So we don't have teams that work with individual doctors. We do have teams that work with individual services. I've been really fighting for us to get more teams working with individual doctors, because then you tend to learn more about the details about that physician and making that team work better. We basically, and the answer that I've gotten when I've asked for it is that we want to make sure that we've cross-trained everybody so that anybody can work with you at any given time. And you know, I understand that. So I've got a bunch of people that have worked with me once every month and really don't know the details. So when we start talking about me needing an EEA with a 3.5 millimeter, you know, load, eyes glaze over and they say, okay, I've got to go out and find it, and they spend 20 minutes going out and trying to find it in a core.
We all experience that.
Yeah. So
Dr. Pruitt?
So Ken, just before Dr. Pruitt gives this award, I think you ought to know what the word of the day is today.
what is it?
Modus operandi, a particular way of doing something, especially a person's typical mode of operation. So you're talking about a bit more precedent.
Well, Harry, we thank you for such an inspiring lecture.
Oh, great.
Dr. Stewart regrets he could not be here, but we want you to have this plaque in our sincere appreciation for your valued participation at the University of Texas Health Science Center Department of Surgery Grand Rounds.
Sir, thank you very much.
That's your honorarium, by the way.
It's perfect. That's all I need.
Before we start M&M,
Thanks for your
Dr.
time.
Dooley from the VA has an announcement.
Yeah, I have a couple of questions back, but I got something. So,
You want to keep that? Okay, sir. Put over that.
Yes, sir. Thank you.
Dr. Zabayos here? Carla Zabayos? She just stepped out there. Did she? Well, Tim, come on up, being accepted for. I'm not going to keep everybody here for over